Welcome everyone to today's webinar. I'm Heather Punke with Becker's Hospital Review. We will begin today's webinar with a presentation, and we will have a time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Lauren Wygand is the Associate Director for Product Management in MD Live's Health Systems Business Unit. Lauren joined MD Live from Nant Health, where she led pre-sales efforts for the population health product line. Prior to that, she managed Nant Health subsidiary iSorona's industry-leading medical device integration software product. Lauren is a former Epic employee and completed nearly 3 years of medical school at Vanderbilt, where, as an undergraduate, she received a BA in chemistry. And we have Dr. Sanjay Patil, who is the Executive Vice President and General Manager of MD Live Health System Business Unit. Sanjay has more than 20 years of experience in clinical practice, hospital administration, physician and hospital joint venture development, and quality management. He completed his cardiology fellowship at Beth Israel Deaconess Medical Center in Boston and received his master's in clinical research and biostatistics. His published research and clinical trial interest focuses on machine learning to identify patients at risk for adverse clinical events. His work on hospital readmission reduction programs use predictive models, biometric monitoring, and EHR workflow decision support to significantly lower heart failure readmissions. Sanjay and Lauren, I'll turn the floor over to you.
Thank you. This is Sanjay Patel. Thank you all for attending today. We're going to be talking about driving value-based care metrics using telehealth. Our goals today will be to examine, our learning goals will be to examine point-of-care benefits to patients and providers from integrated telehealth services within health systems. Also to move from telehealth as a limited service that it has historically encompassed virtual urgent care to a transformation so that it's part of the EMR workflow both for primary care and specialty clinical care. And last but not least, making telehealth a patient engagement and loyalty differentiator for health systems, driving patient portal registration and utilization, and by extension, meaningful use for patient engagement. Next slide, please. We're going to look at the value-based care perspective for telehealth, what it used to be and what it will be off into the future. That's encompassed by the second bullet point, virtual care outlook now and next. We'll also cover the key incentive programs that are in the marketplace presently and the measurements for scoring, and which of those can actually be impacted using telehealth. We'll also examine ways that virtual care can drive value-based outcomes and meet the specific metrics on incentive programs. We'll also have a Q&A session. Next slide, please.
Hello, everyone. This is Lauren Wygand with MD Live, and I'm going to frame things up by talking a little bit about where we are in the marketplace. This is a number that I'm sure most of you are very, very familiar with. Healthcare spend in the United States is over $3.5 trillion with a T dollars. That's a large number, but, next slide, it's going to get much bigger. It's an increase of over $2 trillion with a T dollars in less than 10 years. I think I last saw those numbers on one side of the sandwich board, the other side said the end is nigh. These are scary numbers, but there are things that we can do. Next slide. We know that we have a generation of Americans getting older and increasing their utilization of healthcare services, contributing to that huge jump in spend that you saw in the previous slides. How do we address this? This is a problem of supply and demand. We can approach it from the supply side on the physical angle. We can build more bricks and mortar facilities. We can attempt to train more providers. If we started these efforts now, it's most likely still not going to be enough. But what if we approached it from another angle? Next slide. We can accomplish many of these same aims virtually. Rather than having physical bricks and mortar presences, we can distribute the functions of the care team across whatever organizational or physical barriers are in place today. So rather than needing to hire one full-time employee who is maybe busy an eighth of the time, you can literally hire an eighth of an employee who's also providing virtual care to 7 other facilities. It allows us to distribute our supply in order to meet this growing demand. Kaiser is one great example. Yeah, Sanjay.
Yeah, Lauren, so would it be fair to characterize this as telehealth potentially provides liquidity in the marketplace for clinical services? So historically, you could only get those services at a brick and mortar facility. When you actually look at the potential for telehealth to deliver care, what I refer to as catapulting or launching care outside the traditional borders or the 4 walls of the clinical care facility, you're really providing liquidity as well within the marketplace. So behavioral health services, which may be in short supply or non-existent in certain areas, all of a sudden you've got supply and demand capability. And that's essentially, I think, what Kaiser has described, that they're looking at their virtual visits, which are 16 million now. They project that by 2018, their virtual visits will exceed their brick and mortar visits.
Yes,
Kaiser
60% of their visit volume, which is remarkable. It goes to show how many visits can be handled virtually, adding to that the possibility of that liquidity that you mentioned.
And Kaiser is looking to this to deal with its demand situation, but also to decrease overhead. One of the reasons that we thought it was very important to describe these findings, Kaiser, obviously it's a bit of an unusual creature in that it's both a health plan and it also has health system characteristics in that physicians as well as facilities, inpatient as well as outpatient facilities, they're able to provide virtual care to their members with little or zero copay. And in fact, they try to encourage it because it's better care for the patient and far more efficient. Back to you, Lauren.
Thanks. Next slide, please. So we've talked about virtual visits. We've thrown that term around. When Kaiser says virtual visit and when MD Live says virtual visit, we both mean something that is part of the normal process of providing care to a patient. A virtual visit is not some tacked on sideline animal. It is simply another means, another mechanism of delivering care to patients. In order for that to happen and to truly be effective and adopted, it's absolutely key that it integrates into workflows in ways that make sense. So on the health system side, that means integrating with the EMR, not just in terms of sending a CCD or data back at the end of the visit. It means incorporating the visit directly into the provider's workflow, making it, again, part of the way they deliver care. Simply another alternative. When we say virtual visit at MD Live, we also mean a visit that adds value. One of the questions that we get asked is, what's the ROI on this? You can look at ROI in a couple of different ways. There's the soft ROI that you will see from providing increased convenience, which is another market trend. It's the consumerization of healthcare, and being able to provide virtual visits is a key way to speak to that demand for convenience that we're seeing in the marketplace. You might see years to truly see return in terms of physician and patient recruitment and retention. But another way that you can look at ROI is your hard ROI. And very conveniently, a lot of value-based reimbursement programs have metrics in them that can be influenced either directly or indirectly by the use of telehealth. That's what we're going to spend a lot of today talking about, but keep in mind that these are all ways to get very visible and direct ROI out of your telehealth strategy. Next slide. So that's what we call telehealth 2.0. Again, it's not a sideline. This is a core part of a strategic transformation to deliver care in the 21st century for 21st century patients using 21st century reimbursement models. Next slide. Now, hopefully, most of you aligned with at least one of the programs that we have up on the board here. I'm sure these names are all familiar. I know not all of them will apply to all of you, but one point that I'd ask you to keep in the back of your mind as we go through our subsequent slides, we're going to choose one example from each of these programs, is next slide, is that there is a lot of overlap between what these programs are actually measuring. So if we talk about reimbursement for reduced readmission rates in the context of one program, several other programs have similar metrics. The details might be slightly different, but the core principles of how we attack those problems are very, very similar. And with that, I will turn it over to Sanjay to tackle our first example.
Sure. And before we get underway, could we go back to the grid slide, please? I believe that's slide 12 or 13. There we go. So I'm sure everyone has been fatigued with the number of acronyms. We've got MACRA, we've got ACOs, we now have CPC Plus, we've got MA plans or Medicare Advantage plans, and we've got DSRIP. Fundamentally, all of these programs really force into the marketplace value-based care. And the way they force it into the marketplace, they're really making health plans as well as providers accountable based on very specific measures. What we are trying to do is say, well, let's look at all of the measures, right? MACRA has a set of metrics called MIPS. If you look at the last row here, you've got MIPS, which is Medicare Incentive Program. For ACO, you've got 33 different measures that are adopted or measured against the provider organization. For CPC Plus, you have quite a bit of overlap across the ACO measures. With a Medicare Advantage or a Medicaid plan, you follow HEDIS measures, and that too, it's a subset of the HEDIS measures. You've got yet another program called DSRIP, which is Delivery System Reform Incentive Program, and that applies largely to Medicaid. As you can see on the third row, some of these measures are applicable to providers only, some are applicable to providers as well as payers. The bottom line, you've got all of these different metrics. You've got to catalog who you are. Are you a health plan? Are you a provider? And which metrics become the most important? Amongst the metrics, some are weighted much more heavily than others. Now, let's try and make sense of all of this. If you're a Medicare provider, you've got essentially three options. You are by default put into MIPS, which comes under the MACRA column, so that's the very first one. So those are the metrics that you have to follow. It doesn't matter if you're part of a health system that also happens to have a health plan. If you're billing Medicare, by default, you're put into MIPS, unless you're part of an ACO. There are at least three generations of ACOs. Next-gen ACOs are the ones that take the greatest risk. Prior to that, you had Medicare Shared Savings Program ACOs. There are very specific measures by which ACOs are measured against. Your alternative to participating in an ACO is to be part of CPC Plus. Those providers that have already applied and successfully make it in actually get a different set of incentive payments, slightly different from the way ACOs are structured. So if I'm a provider organization, I fundamentally, if I'm billing Medicare, I'm going to have to follow one of these measurement programs and achieve certain metrics. So the question then becomes, as a provider, which of the metrics can I actually utilize telehealth to try and influence in a positive way? We'll get into that shortly. If I'm a health plan, the second to last column, for example, Medicare Advantage, I've got HEDIS measures that I need to follow. So as a health plan, certain health systems also have their own health plans. They've got to follow these HEDIS measures. And last but not least, at a regional level, you have health systems and practitioners combining forces, essentially, to try and do some sort of delivery system reforms and demonstrate those particular projects. And there are completely different measures associated with those. So you've got this mishmash of, am I a provider? Am I a health plan? Does my provider organization participate in an ACO or CPC Plus? That's the algorithm that you have to go through in terms of determining which metrics apply to you. Go to the next slide, please. So this is where that Venn diagram comes into play. There is quite a bit of overlap, but there are certain measures for each of the programs that are different, that are unique. And so we at MD Live have tried to put together a matrix that allows you to determine which metrics are applicable and can be influenced in some fashion using telehealth. Next slide, please. So as an example, if you're an accountable care organization, one of the measures out there, it's not explicitly stated this way, but readmissions. In other words, if a patient in a Medicare program has been admitted to a facility, how many of those patients, depending upon the diagnosis, actually get readmitted within 30 days? There's an expectation that for a certain percentage of patients based on the diagnosis, inevitably there's going to be some percentage of readmission. In other words, there are certain patients that are going to get readmitted simply because of their comorbidities, their social situation, a whole host of other factors. What's interesting is that effective right now, both health systems as well as skilled nursing facilities are now both at risk for readmission metrics. The goal is for most diagnoses, it varies across different DRGs, you're really trying to get readmissions at or below 16% of the eligible population. Obviously, this number will continue to go down as quality continues to improve. So there are either penalties or incentives depending upon which side of those metrics you're actually on. We believe that a combination of remote patient monitoring for patients that have chronic conditions or at high risk for readmissions, combined with remote video encounters in place of or in the transitional state between a discharge and a follow-up to a primary care physician, will have a significant impact on readmissions. There's a number of additional measures that can be impacted, but this one is probably the most concrete of all of those where we see telehealth playing a role. Next slide, please.
And Sanjay, the number one thing that comes up over and over if you look at studies on reducing readmission rates is communication. And that is exactly what we provide through a telehealth platform. One of the interesting problems is that often in these transitions in care, you see providers that are not on the same technical system. However, if MD Live's platform is in play, we can enable the same telehealth experience regardless of the system that the providers on either side of the transition or the patient primarily align with. Everything flows together. Everyone is connected. With nursing homes in particular, many of you have probably shared my personal experience with having difficulty getting a physical presence of a provider in a nursing home. But what if we could make that provider available virtually, provide that care, and be able to keep the patient from needing to go back into the hospital? These are very possible things, and with MD Live's platform, we can connect these pieces and make them possible.
Thank you, Lauren. I'm going to just walk through some of the other programs and some examples of how these programs are structured. And what we're really trying to do is educate our audience about the different programs that are out there, the different metrics that are out there, and then bring it all back into the perspective of, well, where can I use telehealth to bridge that gap between the patient who might be at home or at the workplace, who is somewhat resistant or has challenges to getting into a brick-and-mortar clinic or facility, and where telehealth might have a role. The Comprehensive Primary Care Plus program, CPC Plus is the acronym that's utilized. It came out of the Centers for Medicare and Medicaid Innovation. Their original program, which was CPCI, was relatively limited in terms of scope. It went on for approximately 4 years, and they looked at encouraging health systems, practices, and health systems to really combine forces, giving them a very specific incentive to start coordination of care well beyond the traditional patient-centered medical home. It's really about supporting an aligned and connected network which has 24/7 access for patients. That's where the track one approach is, practice transformation. These programs really encourage practices by giving them an $11 a month to $23 a month incentive per member. So if I decide that I'm going to participate in CPC Plus, I applied, I was accepted into the program, my practice was. Now for all of my Medicare beneficiaries, there are certain metrics that I will be tracked on, but I'm actually being incentivized to start putting into place within the first year to 2 years certain programs, certain systems in order to actually affect change in those metrics. The real impact is going to be seen approximately 3 to 4 years out. So in CPC Plus, no one is under any illusion that if you implement new systems and new programs within 12 to 18 months, there will be clear outcomes improvement and clear ROI. It's really a longitudinal view of, let's try and put some programs in place for the first 2 years. Hopefully we'll actually see some improvements in year 3 and 4. In the original CPCI program, very dramatic reductions in cost. In some instances, as much as 17% total cost of care reduction was noticed. That's pretty significant. When you look at the total spend on the Medicare population, over a 4-year period, experiencing a 17% reduction in total cost of care, just imagine what the numbers would be like if this were expanded throughout the Medicare program. Next slide, please. Then we have what is referred to as Medicare Advantage programs. Long story short, these are traditionally health plans that administer an offering to Medicare beneficiaries. There are a number of benefits offered to the beneficiaries, certainly in terms of premium as well as coverage and reduced copays, et cetera. These are essentially in-network provision of services. So when a Medicare Advantage plan is affected, essentially you've got a network of providers and health system organizations that may be specifically contracted with that particular plan. The plan itself is rated based on HEDIS measures. So whenever people ask me, HEDIS measures, how does that impact revenue for the plan? It's sort of like describing how the GPA, the grade point average system, works, right? You take a number of different classes, you get your grade in those individual classes, you get so many points, and then all of that rolls up into an overall grade point average. Well, the equivalent of the grade point average is the star rating for a Medicare Advantage plan. You've got all these HEDIS measures. Your plan is measured on things like care for older adults, medication reconciliation and review, fall risk assessment, breast cancer screening, colon cancer screening. A whole host of these different measures apply. That plan is then assessed based on its member population. The metrics are collected. Depending upon the individual metric, there may be greater weight given to certain measures versus others. So overall improvement in outcomes is weighted much more highly. It's given 3 times the weight that than, say, patient satisfaction might be. All of these roll up into composite scores that then give you a star rating. Why is this so important? I think those of you who are participants on this webinar from a health plan are keenly aware of this. The difference between 3.5 stars and 4 stars can be as much as $400 per member per year. Going to 5 stars, even more. So if you have a health plan with 100,000 members and you're able to achieve 4 stars, the difference between 3 and 4 stars is in the tens to hundreds of millions of dollars. There's every reason that you want to try and get those measures to where they need to be. One of the biggest challenges is that members need to actually come in and get assessed and have the appropriate screening, the appropriate services ordered. Historically, that almost always meant that they had to come in either for a reactive clinical event or an annual wellness visit. That's when you historically tried to address these. Well, with telehealth and within a Medicare Advantage program, a number of these measures can actually be impacted using telehealth. And we'll walk through some of those examples. Next slide, please.
Mm-hmm. And when we talk about the challenges of getting patients to come in, I think of 2 categories of barriers. There are the barriers that you typically see with your older, sicker patient population, where there's challenges with transportation, general infirmity, just struggles getting around. Telehealth can be very valuable in being able to allow the PCP and the patient to maintain that relationship and have those discussions while the patient stays in the comfort and convenience of their own home. A second group of patients are, frankly, the younger generation who are, well, they consider themselves too busy to come in during traditional business hours. It can be very challenging to get these folks in to sit down in that exam room chair in the office. Again, by providing telehealth, and particularly by providing after hours accessibility to physicians through telehealth, you can reach these patients and address these items that Sanjay is talking about.
That's exactly right. Our thinking is virtual urgent care. Historically, telehealth was all about convenience, right? I think the model was very similar to Uber or Lyft. I need a car right now. I need a driver right now. Let me look at my app. Let me specify where I want to go. And I can actually find someone who's got the capability to drive me to where I want to go. And I can get an estimate of price. And for the driver, when demand surges, they can actually receive more in the way of compensation, the classic surge pricing. In healthcare, unfortunately, Uberization of healthcare, I don't see that happening in the near-term future. Certainly, you can get on-demand urgent care. Unfortunately, surge pricing doesn't fit into the equation today. So what we're seeing is an attempt to address what we're seeing in other verticals, Uber being the best example, wherein you've got instant availability of a doctor who can do an assessment and perform an intervention like a prescription or orders. Well, let's take that a step further. Let's take it out of the urgent care model, and let's see what we might be able to apply that to in terms of impacting these metrics, whether you're a provider or a health plan. Here's some numbers that look at the various HEDIS measures and their impact to a specific health plan. This particular health plan has a very large number of members, hundreds of thousands actually, and they're being measured on a whole host of HEDIS measures. So if you go down the row there, you've got breast cancer screening, colorectal cancer screening, adult BMI assessment. Care for older adults. If you go further down, roughly just past the halfway mark, C13 and beyond, you've got diabetic care, eye exam, diabetic care, kidney disease monitoring, and blood sugar control. Bottom line, C13, 14, and 15 would traditionally require one of these members to actually go to a facility, get an eye exam done, or go to a facility and get blood work done. Well, how do we address all of that? With telehealth, we've got the ability to actually confirm with the member that they've not actually had these particular diagnostic studies or interventions performed. We can then initiate the order, and here's where the Uberization component comes in. There are a whole host of in-home service providers that can then reach out to that particular member and schedule time to visit them either in the workplace or at their home. So this is no different than somebody calling you up and scheduling time with you for a life insurance physical, right? I mean, you get called, you set the appointment, they come to your home, they identify themselves, they do a health history, they might have you step on a scale, they measure a blood pressure, they may or may not draw blood. Well, there are a number of in-home service providers, Pager.com, Igbo, Matrix Medical, a number of them that have varying degrees of presence throughout different parts of the United States. We at MD Live are able to initiate the order as appropriate, determine if there is a service provider within that particular locality, and then allow them to dispatch whoever is appropriate for that particular member. The alternative, if the member does not have a primary care physician and really needs to be seen in a clinical site, certainly they can get in with a health system facility, also through relationships with Walgreens in-store clinics, amongst others. A member can go to the most reasonably located pharmacy location and actually have their assessments done with a nurse practitioner. So this is end-to-end care. In the ideal scenario, this would all happen in the patient's home. Now, the reason that this particular slide is important, look at the dollar value of closing some of these gaps for a given plan. And the very first question that I had when I was presented with this grid was, why is there such a huge difference in the value? I mean, for example, rheumatoid arthritis management is $588. Osteoporosis management for women who've had a fracture is $1,300, whereas adult BMI assessment is only $15. The bottom line, it has to do with the complex calculation of how an individual measure is weighted, in addition to the prevalence of that particular gap in that member population. So we look at this and we said, wow, at MD Live, we have several hundred providers licensed across multiple states. Historically, they were doing virtual urgent care, taking care of upper respiratory infections, conjunctivitis, rashes, uncomplicated UTIs, that sort of thing. Why not extend that into the realm of working with our health plans and employers, and certainly our health systems who are taking on risk, and try and effect change in these particular metrics? It's the same sort of skill set, but we've got to be able to integrate in with these in-home service providers. We currently have some projects underway testing that hypothesis and allowing us to really optimize this both from an information systems and technology perspective, as well as scaling with our network of both providers as well as in-home service agencies, if you will. Next slide, please. So DSRIP, Delivery System Reform Incentive Program, is really focused on the Medicaid population, different metrics, heavily focused on behavioral health, chronic condition management, as well as chemical dependency program support. This is really separate. An individual provider, for the most part, does not go and apply for a disrupt program grant award. That's usually done at a regional level. We've had scenarios where we've got 15 or more counties associated with provider networks and health systems all apply for a grant. As an example, New York State has a disrupt grant that's then apportioned out across different parts of the state. The total grant is $8 billion. That's $8 billion with a B. So these are all programs that really focus on coordination of care, and we believe that telehealth is a critical component of that. Next slide, please. So, that helped us evolve our solution into what it is today. And Lauren, being our product manager, is probably best suited to discuss what our solution looks like today. 1.0 was really what we referred to as virtual urgent care, low acuity or on-demand care. Lauren, tell us about 2.0.
2.0 is the future. Everything that Sanjay discussed, all of these converging needs from the market, from reimbursement models, from the way that health systems are delivering care, the way that health plans are operating, the way that everyone is engaging with their patients. We see a role for telehealth in impacting and improving matters for all of these stakeholders. We're looking at this from a very integrated and holistic approach. Health systems have needs, so do plans, so do patients. So that's why when we talk about having integrated and informed virtual visits, we're looking to ensuring that there is adoption and utilization. We could have the world's greatest product, which I fully intend to ensure that we do have, and if no one uses it, then no one gets any value out of that. So we firmly believe that if you're looking as a health system to adopt telehealth, that it needs to be something that is integrated smoothly into the workflow for your physicians. This should be something that uses your assets, meaning your providers, your technical infrastructure investments, including your EMR, as well as your brand.
So Lauren,
yes.
Lauren, so that's in the context of a health system. Mm-hmm. From a health plan perspective that may not have an EMR, we've got this product. Will the product actually help a health plan without the network? Certainly a health system has its network of providers, but in terms of the product offering as it pertains to large employers and health plans, could you speak a little bit to that?
Absolutely, Sanjay. I was just about to talk about what we mean by informed virtual visits, and that is a key part of the value that we provide in those contexts. And this holds true for health systems as well, because as much as we would like all of the information about a single patient to be concentrated within a single EMR, we all know that isn't always the case. If you're a health plan, that is even more not the case. So being able to aggregate the information about the patient and identify actionable pieces of information that can be addressed through a telehealth context can really drive value on the large employer and health plan side. With the health system, I talked about the value of using your own providers and leveraging the relationships that you already have with your patients. With the health plan, depending on the relationships that you have with health systems that participate in your plan, you can do the same thing with that relationship, or alternatively, work with MD Live's physician network to provide that level of physician service. Now, in that case, what MD Live physicians would be doing would not, and I emphasize not, be replacing the role of the PCP. Really, they'd be making the PCPs look good. PCPs do a great job, but if the patient doesn't come into them, they have no way to do that great job. And that's where we can come in and help by trying to reach some of these patients through telehealth when bricks and mortar efforts have not been successful. And in all of these contexts, leveraging those existing infrastructure investments, tying things together. I talked about the importance of communication, the importance of liquidity, the importance of being able to put all of this on a platform so that we can get people talking to each other. That's where magic really starts happening, is when we start connecting patients, payers, and providers all together. And again, going back to that discussion about hard ROI, this is where you can tie the things that you're tackling through your telehealth strategy to specific metrics that have very specific dollar signs associated with hitting certain targets. And aligned with all of that, of course, is being able to produce the documentation to support those efforts. All of those things come together and deliver value in a way that we believe is transformational and hopefully should evolve the way that the market overall looks at telehealth as a solution. And that's telehealth 2.0.
Okay, thank you, Lauren and Sanjay, for that fantastic presentation. If you guys are ready, we will now begin today's question and answer session. As a reminder to our audience, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for today. All right, Lauren and Sanjay, the first question from the audience is, lately I've been hearing references to documenting disease burden in the context of various incentive programs. Is this something that could be addressed with virtual care?
Yeah, so this has to do with what is colloquially referred to as risk adjustment. So documenting disease burden. Now, if I'm a health plan and you're a member and you've been a member for a year and I've received no claims for diabetic meds, I've received no visits that have any diagnoses of, say, peripheral vascular disease or heart failure or any of these what I call high-cost comorbidities. I, as a health plan, really need to do everything possible to reflect what my population, my disease burden, and therefore risk is within that particular population. So how do I do that? Well, I've got to encourage my members to go in and have a visit of some kind. And traditionally, that meant going in and getting a scheduled visit. What we have is an opportunity, certainly not in the Medicare Advantage world yet, but for the QHP plans and certainly commercial plans, a physician, a licensed practitioner connecting with a patient either over the phone or by video and confirming what their history is, why they're on specific medications, and then initiating the relevant orders to document what that disease burden may be. That's key. That's very, very important. Disease burden, for those of you who may not be fully aware of it, can represent anywhere between $800 to $2,000 for a given member when appropriately documented. So telehealth, to sum it up, when we know that we're interacting with a patient who might not otherwise come into a brick and mortar facility during the course of 6 months or a year, we've got the ability to engage with them, to confirm these diagnoses, to address any confirmatory testing that needs to be undertaken, and then obviously not only code that in the claim for that particular visit, but also put it in the encounter documentation. Next question.
Great. Thank you, Sanjay, for clarifying that. The next question from the audience is, what do you consider to be the most important or first step in EHR integrated workflow for virtual care?
So, from integration into the workflow, I can tell you that, my bias is as a provider. Providers resist change whenever they possibly can, right? They're creatures of habit. Throughout their undergraduate, their medical school training, and their residency, they were always taught really to conform, right? I mean, the key was you have to conform. Well, being a conformist means adhering to specific standards, which also means not changing, resisting change whenever possible. If I'm using an EHR and I'm using that particular workflow, I'm going to resist if I have to go to yet another system and document, learn how to document elsewhere, and do that out of context, so to speak. EMR integration or EHR integration is paramount. As a provider, if I'm seeing patients or I'm following up on results on a patient, I want to have that full footprint or fingerprint, if you will, of data with regard to the patient, and I need to be able to not only initiate that visit, but document as well as perform order entry or e-prescribing all in one. The only way that's accomplished is integration into the EHR. We feel very, very strongly with our health system clients that unless their providers are using telehealth in the context of their EHR workflow, it's simply not going to yield value. It's just that the potential will be unmet. Next question.
Great, thank you, Sanjay. Let me pull up the next question from the audience. My apologies. Okay. Will there be Medicare reimbursement coming to telehealth in 2017?
So it's an interesting question. If you look at the Medicare fee schedule, telemedicine reimbursement has always been there, but not in the context that we're talking about. There's always this component of distant site and originating site, which under Medicare, for the most part, not exclusive, for the most part, essentially means a patient has to go to a specific facility, and a provider can be at a remote facility, if you will. That's been there for a very, very long time. It really allowed rural areas or underserved areas to actually have medical care delivered from a remote setting. The criteria for reimbursement were quite onerous. It really hasn't achieved as much potential in the marketplace as it could have. So in general, the answer is it's not there in a significant fashion, with one major exception. That is for chronic condition management. The chronic condition management codes have been there for quite some time. If you look at the code, depending upon the geography, you get anywhere between $41 and $53 per member per month, as long as there are 2 chronic conditions. You're supposed to interact with the patient at least 20 minutes a month. Technically, the interaction doesn't have to be 20 minutes. It's 20 minutes non-face-to-face interaction and review of the data and coordination of care. So we believe that chronic condition management, it's a natural as far as the utilization of telehealth. But again, you've got to be able to launch that out of your EMR. You've got to be able to document the time. You've got to be able to do all of those particular pieces. So the virtual care platform that we built does precisely that. That the handshaking that goes on with the EHR allows you to document the amount of time spent and give you full insight into what's going on with the individual patient, allowing you to document the full 20 minutes. I suppose another way of looking at it is if you're part of a Medicare Advantage plan and you're a health system that's taking risk, you get to determine what the compensation or reimbursement will be to physicians. We do have health systems where they're at risk, and this could be Medicare or non-Medicare. They're fully at risk. They incentivize their physicians by giving them RVUs for visits rendered using telehealth. So whenever you're at risk as an organization, and Medicare Advantage is probably the closest thing to Medicare coverage in terms of this question and the answer that I'm giving, that's when you actually see some degree of reimbursement. You've got that flexibility. But reimbursement as a whole, it's really not where it needs to be for general Medicare. Next question.
Great, thank you, Sanjay. The next question is, Could you discuss the impact to the BPCI or CJR?
Yeah, so incredible amounts of interest on bundled payments. So bundled payments initiatives, the most common has been on joint replacement. We're seeing that expand into other areas. We are getting a lot of interest from our health systems as well as extended care facilities. So these could be skilled nursing facilities, inpatient rehabilitation, and by rehabilitation I'm talking about physiatry, not chemical dependency rehab, as well as long-term care within the nursing home setting. So bundled payments, essentially the organization receives a single bundled payment for all care of a particular DRG over a period of time. The biggest issue there is reducing complications and reducing readmits. So telehealth comes into play just like it does with any other chronic condition management or transitions in care and readmission reduction strategy. So telehealth is, I think, very important in bundled payments, but even more so in terms of skilled nursing facility or long-term care. These are patients that, number one, don't get monitoring in the traditional sense or engagement other than when a practitioner visits that skilled nursing facility. You could extend the same model to assisted living and independent living facilities. We feel strongly that telehealth will impact overall cost of care and readmission significantly in those populations. Next question.
Perfect, Sanjay. I think that helped us understand. The next question is, how do you motivate physicians to embrace telehealth when reimbursement rates for their telehealth sessions are significantly lower than in the clinic? When the physician operates outside their regular hours, is that not going to increase burnout?
Absolutely. So I think that the model of having physicians moonlight and do virtual urgent care, is very challenging, right? If you've got primary care physicians as well as specialists, they're already working incredible hours. They've got all sorts of demands on their time. There's all sorts of requirements from a documentation perspective. Trying to do any of this at a reduced reimbursement relative to face-to-face visits simply won't work. However, our health system partners have decided to be very creative to incentivize their physicians. We have certain health systems that are visionary, and they recognize that as they take on risk, they're going to have to deliver care in the most efficient manner possible. That's where telehealth comes in. So they are incentivizing their physicians, either equally or in some cases, giving them incremental additional RVU credits for telemedicine or telehealth visits, especially when the organization is at risk or the economics make sense. We have one organization in Southern California. Their physicians have to drive out to high desert. They've got a lot of windshield time. So they came up with a very creative solution, and that was encourage telehealth visits and comp their physicians, because ultimately they would have to compensate their physicians for that windshield time. It just didn't make sense. It wasn't efficient. In addition, these patients who had to come into these high desert clinics were driving in from 20, 30, 40, even 50 miles away. Telehealth made all the sense in the world in that particular scenario. So the straight answer is you've got to be forward-thinking and realize that, much like Kaiser views this is the future. You've got to start someplace. If we wait for Medicare and commercial reimbursement to catch up as far as telehealth, everyone will be scrambling. So there are organizations that have decided we need to embrace this. We need to get this as part of our culture, both for our Medicare population as well as commercial. We've got these millennials that have increasing both expectations as well as purchasing power, and we really need to embrace this. Next question.
If I could add in one point, It wasn't too long ago when the concept of a hospitalist was not a common thing. We actually anticipate the role of what we're calling a virtualist emerging. In the same sense that hospitalists can handle that overnight type care for admitted patients, we foresee the rise of the virtualist specialty specializing in delivering virtual care and potentially helping to ease the burden of some of those odd hours.
Yeah, and to echo what Lauren has just described, you know, in the early days, you described people as either a specialist or a general practitioner or a generalist. Then you had folks that focused only on the ambulatory setting versus hospitalists. We see an emerging specialty called extensivists. These are physicians who deal with patients transitioning from an acute care or hospital setting, either going to home or to some form of an extended care facility. The logical extension of this is the virtualist. Why do we think this is going to be somewhat different from all the others? There are certain things that you can actually do effectively with virtual care or telehealth, and there are certain things that you simply can't. And understanding or consuming the body of knowledge about what's appropriate and what isn't, what works and what doesn't, that's where we think that the concept of the virtualist will be more than just a concept. We think it'll be a specialty in and of itself. Next question.
Interesting. Thank you both. It looks like we have time for one more question, and that is, what is the administrative burden associated with telehealth sessions? Is it similar to the clinic setting?
And the specifics on that are going to depend a bit on the services that you offer and the mix of staff that you use to provide those services. What I can say is that Stanford recently launched a virtual clinic, and they found a 30% reduction in their administrative burden compared to comparable bricks and mortar clinics.
Perfect. Thank you, Lauren. And that is all the time we have for today. So I want to thank Lauren and Sanjay for your excellent presentation and to our audience members for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you to our audience.